Should I just begin talking? Is that right? For some time, we have dreamed of applying the techniques of organ transplantation to children with crippling kidney and other sorts of disease, which have long been used in adults. And we have been working at Children's Hospital towards that goal for over 2 years, during which we have been preparing, integrating a team, and in the past 2 weeks, we have begun with our first kidney transplantation in a 2-year-old boy with otherwise fatal kidney disease. And we feel very pleased that we have made this beginning, because we think that there's possibility of salvaging life and function in such a child. And we have here Dr. Randolph, who is the chairman of our Department of Surgery and represents the surgical part of the team, and Dr. Popadopalo, who is our nephrologist and is the physician of the first recipient, as well as our expert on kidney disease. Maybe Zoe, you'd be willing to say a few words about our first patient.
Our first patient is now 26 months old. He was first admitted to our hospital at the age of 11 and a half months with the diagnosis of the hemolytic uremic syndrome. This disease is known to affect the kidneys in a marked way. The child, upon admission, was already in heart failure and in acute renal failure. With medical treatment, he improved markedly. However, the damage to the kidneys was quite severe, and he remained in chronic renal failure. For the past 14 months, we have been able to maintain this child while in kidney failure on a special diet, fluid restriction, several medications, and intermittent peritoneal dialysis. He has done very well, and he recently received a transplant very successfully.
I might mention that it was really quite a striking thing to see a child who had essentially been reduced to no effective function whatsoever of his kidneys a few days, and been on a very restricted diet, a few days later sitting up in bed, watching television, and eating potato chips. And perhaps Dr. Randolph would be willing to discuss some of the surgical problems in doing a heroic job like this. Dr. Randolph.
I'd like to underscore what's already been said about the team effort. It's interesting that when we began this concept of transplantation for replacement of certain organs that fail in babies and young children, that all of the family of Children's Hospital was involved. Dr. Robert Parrott, our director, helped us put together this team. Mr. George Hamilton, our president of the hospital.
In the whole category of smaller children and infants who have died of fatal kidney disease for which transplantation was not really available, has been done in smaller children. But this does represent innovation in an area that we think is important. The second child, who was done today, obviously we couldn't have known about when we originally thought about meeting with you today, and is a child who had large losses of urine, of protein into the urine due to what we call congenital nephrosis. This is an invariably fatal disease, and this child had reached the point of cessation of growth. So we were left with a child who each month that passed would be farther and farther from her expected milestones in growth and development. We felt that some sort of intervention was necessary to allow her to once again have adequate kidney function, adequate growth, and rejoin the world of more normal children.
It's children under 5 years of age have undergone transplantation of their kidney with varying degrees of success. I'm sure you can understand that the techniques that are necessary as you scale down the age and size of the individual become increasingly complex because you're dealing with progressively smaller and smaller vessels. And the vessels in our 5-month-old today really are very quite tiny, difficult to sew together, difficult to maintain blood flow through. And so these are areas that require continued study, are additional reasons why kidney transplantation might fail in the baby rather than just the rejection process, which is the main hurdle for the adults to overcome. That's an interesting question. I'd like Dr. Avery to answer that because of his work in newborn immunology.
So I think that's something that many people have wondered. It certainly is clear that newborns do reject grafts and that it's not a privileged period in which you can graft at will without immune suppression. On the other hand, the size of the immune garrison, if you can use that term, is smaller in children, and the possibility of eventually figuring out strategies for inducing tolerance have their greatest promise in children. And not only that, but the need to induce tolerance, to get a strategy to avoid giving large doses of immunosuppressant drugs is greater in children because the immunosuppressant drugs can also impede growth. And it's very, very important for the recipient, who is only 6 months old, to be able to continue growing and to reduce as quickly as possible the dose, particularly of the adrenal steroid type of immunosuppressant drug.
A little child, unfortunately, who was in an automobile accident and was severely injured, including a severe head injury, which ultimately caused her death. It was finally predictable on the part of our neurology service that this child was about to die, and we secured very good cooperation with the parents who understood the potential for some of their child's tissue to help save another child when their child was beyond help. In the case of the second baby, as I mentioned earlier, we have the problem of size and fitting vessels one to the other. And an unfortunate baby was born in the Washington area with anencephalic problems, which mean without any brain. And these babies live only a matter of hours without any support or even with all known medical means today. And this is in Dr. Avery's area to care for these babies and be able to predict their death so that perhaps their tiny organs might be preserved and used in such an operation as was done this second time today.
How long did the operation take?